Hello and welcome to my YouTube channel. Continuing our series of surgical emergencies, today we will be talking about a very important topic, and that is a hollow viscous perforation. I hope that at the end of this topic, as MBBS students who are doing their surgery rotation and also postgraduate residents, they would be able to tell you a few important things about the investigations and the management protocols of few common conditions which would lead to this acute surgical emergency and an important cause of acute abdomen. We would be covering this topic under the following heads. First, we would see what exactly is meant by hollow viscous and what are the different classification types. We would also discuss very important etiologies and the types of hollow viscous perforation. A word about pathophysiology, which is very essential to understand and to plan your management accordingly. Clinical features, investigations which would be done in specific situations, and a word about resuscitation, and then we would end our topic by discussing about the surgical management of common conditions which would lead to a hollow viscous perforation leading to peritonitis, and finally a word about few important emphasis on examination points which you're supposed to know if you're appearing for your say clinical examination or even a theory examination. So without wasting further time, let's get started and cover this important topic. Now, a hollow viscus is any gastrointestinal or a urinary organ that has a lumen. That's the basic definition of a hollow organs. Now, here we would be concentrating more on a gastrointestinal system. And what exactly if you meant by the term perforation? It means a full thickness breach allowing the luminal contents from the lumen to escape into the peritoneal cavity, and this would later on cause of triggering a sequence leading to ultimately to a perforation peritonitis and its associated complications. Now, if you see the gastrointestinal system, we have few important causes of hollow viscous perforation which can cause ultimately peritonitis. So if you start from esophagus, one of the most common cause of perforation of esophagus would be instrumentation. If instrumentation, of course, now today we have in today's world we have a flexible endoscopes, but if a OGDS or a esophagogastroduodenoscopy is done incorrectly, or if there is any other form of instrumentation, if not done in a proper way, it can lead to perforation of esophagus leading to mediastinitis and its associated complications. Another very rare cause of esophageal perforation is Boerhaave syndrome. Now, what exactly is a Boerhaave syndrome? Here there is a esophageal perforation, especially in the lower part of the esophagus on the left side, and this occurs because of a sudden increase in the intraluminal pressure within the esophagus. And why this increase in intraluminal pressure would occur? This would occur because there is a prolonged bout of intense retching and vomiting. This can occur following an alcohol binge or any other cause which can lead to a prolonged forceful retching and vomiting. Now, what it does is it causes a typical triad which is known as Mackler's triad. Mackler's triad. Now, what exactly this triad consists of? It consists of persistent vomiting, which generally precedes the Boerhaave syndrome. This is followed by the perforation of the esophagus leading to escape of the contents into the mediastinum. So this causes intense chest pain. And lastly, there is a subcutaneous emphysema. So these three important features, that is persistent vomiting preceding the onset of an intense chest pain followed by subcutaneous emphysema, together these three constitute Mackler's syndrome in Mackler's triad and Boerhaave syndrome. Now, coming to stomach, which is a more common as compared to esophagus, we have one of the most common cause of perforation, gastric perforation, is a gastric carcinoma, and of course gastric ulcers which can occur, or erosive gastritis which can occur following NSAID injection or even in a peptic ulcer disease. Coming to duodenum, peptic ulcer disease is the most common form of duodenal perforation. Duodenal ulcer, as we know, perforates most commonly anteriorly, and we had seen in our last slide, and they generally bleed most commonly when they are situated posteriorly. Now coming to small gut, in the small gut there are different causes of leading to small bowel perforation. It could be traumatic. If there is a sharp or a penetrating abdominal injury, it can perforate the small gut, leading to perforation of small bowel, leading to peritonitis. There are certain pathological conditions also which can lead to perforation of small gut. In India especially, typhoid is fairly common, and in some tropical countries, whereas inflammatory bowel disease, especially Crohn's disease, can also lead sometimes to small bowel perforation. If you come to large bowel, again it's one of the common site of perforation, and carcinoma of colorectum. Colorectal carcinoma is one of the commonest sites, commonest cause of large bowel perforation. In elderly people, elderly population, diverticulitis still remains one of the common cause which can lead to a large gut perforation, especially on the sigmoid colon and descending colon. Gallbladder perforation is not so common. It generally occurs following a gangrenous cholecystitis, which basically, or it could be a empyema of the gallbladder where there's an accumulation of pus within the gallbladder, and that can also perforate, leading to peritonitis. Now we'll go one by one, as seen in the duodenum, which is one of the commonest sites, especially in the first part of the duodenum, which is a commonest site of duodenal ulcer perforation. They are commonly situated anteriorly, and as we are aware, the commonest cause of peptic ulcer disease is H. pylori infection, which is seen in more than 60 to 70% of patients of peptic ulcer disease. NSAIDs ingestion over a prolonged period of time, as well as aspirin, is also known to cause peptic ulcer disease. Then of course there are stress ulcers like Curling's and Cushing's ulcer, which are commonly seen in one is in a setting of increased intracranial tension, like a severe head injury, and the other one, the Curling's ulcers, are commonly seen in severe burns or any cause of sepsis. Zollinger-Ellison syndrome, leading to multiple ulcers in the duodenum and stomach, is also one of the, though not so common, but one of the causes of ulcer perforation. So duodenum is one of the most common sites of hollow organ perforation, leading to peritonitis. Then we come to small bowel. As we have seen, typhoid fever, especially affecting the terminal ileum, is one of the commonest cause of perforation in tropical countries and also in India. Crohn's disease, inflammatory bowel disease, which specifically the small bowel is affected by Crohn's disease. Meckel's diverticulum, seen in approximately 2% of population, if it gets inflamed, leading to Meckel's diverticulitis, is also a danger of perforation, leading to peritonitis. And of course, penetrating or blunt abdominal injury leading to small bowel perforation remains one of the commonest cause. It could be more commonly a penetrating trauma like a knife or a bullet injury, and of course ischemia, acute mesenteric ischemia leading to ischemic necrosis of small bowel and ultimately perforation is also one of the common cause of small gut perforation. Coming to large bowel, carcinoma colon remains one of the commonest cause of large gut perforation. And why it occurs? Initially, as we already know, that the lesions which are present on the left side of the gut, that is the descending colon and sigmoid colon, are more annular. That means the constricting lesions. So as they occlude the lumen of the gut, it would lead to increased intraluminal pressure proximally. It would also lead to compromised blood supply, leading to ischemia, and this can cause a blowout or a perforation of the bowel. In fact, it is a golden rule that any elderly patient who comes with acute intestinal obstruction and followed by signs of peritonitis, and that is his first episode, carcinoma colon should be ruled out as one of the important causes of this complication. Diverticulitis leading to perforation of large bowel remains one of the common cause, especially in elderly population. Volvulus inflammatory bowel disease affecting the large gut, especially the ulcerative colitis, and instrumentation like colonoscopic injury, if done incorrectly, would also lead to large bowel perforation. All these conditions affecting the large gut are more common in elderly patients. In stomach, it is not a so favorable site for perforation as compared to other sites which we have discussed. However, gastric carcinoma, stress ulcers, chronic NSAID ingestion leading to erosive gastritis, any corrosive poisoning or corrosive ingestion, or any other complications following a post-sleeve gastrectomy and anastomotic leak can also lead to perforation of the stomach wall leading to peritonitis, though it is less common and very uncommon as we have seen on gallbladder perforation, especially the gangrenous and empyematous cholecystitis. Now this is a classical picture of a D1, duodenum first part, perforation of the ulcer as seen here very classically. On the right side, just under the liver, you would be able to appreciate the perforation as pointed in this photograph, and classically it is seen on the interior wall of D1, the first part of the duodenum. Now the moment it perforates, there would be escape of contents leading to peritonitis, which we would discuss in more detail in pathophysiology. This is a classical case of multiple perforations of terminal ileum, which is a favored site of typhoid perforation. Again, it is not so commonly seen in westernized or developed countries, but it remains a problem in few of the tropical countries where typhoid is prevalent or enteric fever is prevalent. Just a word about pathophysiology. It generally goes through different phases, this hollow viscous perforation. If you see the phase 1, following a perforation, which generally occurs in the first 2 hours following a hollow viscous perforation, the intraluminal content, especially the gastric acid or bile or pancreatic enzymes or even intestinal contents, would spill over into the peritoneal cavity. They would spill over into the peritoneal cavity. The peritoneum has a large serosal surface. So initially it is just a chemical irritation which causes a sudden, severe, intense pain. Mind you, there has been no bacterial contamination in this first phase which occurs in the first 2 hours. So it's just a chemical irritation of the serosal surface of the peritoneum once the intraluminal contents escape into the peritoneal cavity. Excuse me. Now this severe pain is seen initially in the first 2 hours. Then the patient enters into the phase 2, which typically occurs from 2 hours to 12 hours post perforation. Here the gut flora starts to colonize the peritoneal cavity, especially the gram-negative organisms like E. coli, Klebsiella, and certain anaerobes like bacteroids. They proliferate rapidly. The peritoneal inflammation intensifies and the fibrinous exudates forms tries to wall off the contamination. So here now it has gone into that classical bacterial peritonitis. Now here the body tries to contain the damage by walling off the spillage by forming a fibrinous exudate wall. Now the patient enters into the third phase, which lasts from 12 to 24 hours post perforation. It is a phase of generalized peritonitis because the containment has failed as the leakage is continuing. The infection spreads rapidly, mainly the gram-negative and anaerobics, and this leads to intense generalized peritonitis where the peritoneum becomes a massive absorptive surface for endotoxins and bacteria. And then the third space, fluid loss, begins. What is the third space? The fluid would accumulate in the bowel wall, leading to bowel wall edema. It would also accumulate in the peritoneal cavity, leading to ascites. And as a protective measure, paralytic ileus ensues in a setting of generalized peritonitis. So this phase of generalized peritonitis lasts from 12 to 24 hours if there is no surgery done within that time. And then the patient phase into The terminal phase, the phase 4, which is beyond 24 hours. If the leak still persists and no initial treatment has been instituted or any definitive management has been done, then the patient is in danger of going into sepsis and multi-organ dysfunction syndrome leading to multiple organ failure. Because of this, there is a systemic inflammatory response syndrome which occurs. The patient goes into sepsis leading to cardiovascular collapse. Kidneys are at risk of failure leading to acute kidney injury or acute renal shutdown. Patient can go into acute respiratory distress syndrome, hepatic dysfunction, disseminated intravascular coagulations, ultimately leading to multi-organ dysfunction syndrome, which has got a very high mortality of almost 40 to 50%. So all efforts should be made to contain this perforation in the initial phases, that is phase 1 or phase 2. If treatment is done, definitive management is done in the initial phases, very unlikely that patient would go into the third and the fourth phase. Now, why the patient deteriorates? Let's try to understand based on the pathophysiology. The first and foremost is that there is a third space fluid loss in hollow viscous perforation with peritonitis. Third space fluid loss means there is a massive fluid shift from the vascular compartment into the peritoneal cavity as well as in the gut wall or bowel wall. This would lead to bowel wall edema. Now, this shift, there is no external loss, it is just a third space loss from intravascular to third space, leads to hypovolemic shock. And this hypovolemic shock can lead to ischemic and hypovolemic damage to target organs, especially the kidneys, which are so sensitive to ischemia. So patient can go into a pre-renal acute kidney injury leading to acute renal failure. Another common condition which occurs is metabolic acidosis. Now, metabolic acidosis occurs because there is a poor tissue perfusion. This could lead to cellular hypoxia. When the cellular hypoxia occurs, the metabolism shifts to anaerobic metabolism and the lactic acid is generated, leading to lactic acidosis. And how a lactic acidosis is recognized? Of course, on acid-base gas analysis, the pH would be less than 7.35. That is the first finding on ABG. High lactate, more than 2 milliequivalents per liter. More specifically, it can go beyond 4 milliequivalents per liter in severe sepsis. And of course, base deficit. So metabolic acidosis also is one of the important ways, one of the complications which can lead to more increasing morbidity and mortality. As we have seen, paralytic ileus always occurs in a setting of generalized peritonitis, and because the peritoneal inflammation inhibits the autonomic plexuses of the gut wall. So the effective peristalsis ceases and this would lead to a silent abdomen. So a silent abdomen in a patient of peritonitis is not a good sign. Patient can also go on to develop coagulopathy leading to disseminated intravascular coagulation. Why? Because the widespread inflammation would activate the coagulation cascade. This coagulation cascade would lead to consumption of clotting factors, leading to consumptive coagulopathy, which ultimately leads to disseminated intravascular coagulation, causing intense bleeding and clotting simultaneously. So this is also one of the important complications leading to increasing morbidity and mortality. Diaphragmatic splinting. Peritoneal irritation which occurs under the diaphragm causes referred pain to the shoulder tip mediated via the phrenic nerve. The root value is C3, 4 and 5. This would lead to a shallow breathing leading to hypoxia, which would further aggravate the ischemic damage which the patient is also tolerating. It can also cause abdominal compartment syndrome because the massive edema of the bowel wall can lead to increased intra-abdominal pressure. Now, increased intra-abdominal pressure, if it goes beyond 20 millimeter of mercury, then abdominal compartment syndrome can occur. And this abdominal compartment syndrome would compress the great veins like in inferior vena cava and the renal veins. It would also splint the diaphragm. The return to the heart is compromised and patient can go into cardiorespiratory failure. And lastly, these patients are at risk of sepsis and endotoxemia because gram-negative bacteria releases lipopolysaccharides, LPS. Now this LPS causes massive cytokine release, activation, TNF alpha, tumor necrosis factor alpha, interleukins 1 and interleukin 6 specifically, and this leads to widespread dilatation leading to septic shock. So this is a pathophysiology which would lead to the deterioration in the patient with generalized peritonitis. Now coming to the clinical features, history and examination, patient would complain of sudden severe onset catastrophic pain. Patient can recall the exact time because the pain is so severe and it occurs suddenly when the actual perforation occurs. The site of the pain would depend on the type of the organ, anatomical location of the organ which has been perforated. For example, in case of stomach or duodenum, there may be pain in the upper abdomen, especially in the epigastrium and right side of the right hypochondrium. If it is in the lower gut, say in the colonic perforation, then the pain may be lower down initially. The character of pain is described as knife-like severe pain depending on the site of the perforation, and gradually it spreads to the whole abdomen, and also patient may complain of pain in the right shoulder tip. There may be associated nausea, vomiting. The patient is reluctant to move when the peritonitis sets in because any movement would aggravate the pain. So patient prefers to lie still because there is an inflammation of overlying parietal peritoneum, and this would make any movement aggravates the pain. So patient generally lies still on the bed. If you take a history, there may be a history of a known case of a peptic ulcer disease, or maybe a trauma, or a history of typhoid fever or NSAIDs. When you examine the abdomen, on inspection, the abdomen may be distended. Patient prefers to lie still. When you palpate, classical description is board-like rigidity, which is an involuntary guarding of the anterior abdominal wall musculature. Rebound tenderness may be present, generalized because of the inflammation of parietal peritoneum. If you percuss, there would be loss of liver dullness because the gas would occur between the liver and the anterior abdominal wall, and this would lead to loss of liver dullness, which is commonly seen on percussion. And if you auscultate, we have already discussed, because of paralytic areas, the bowel sounds may be absent, or in the initial stages it may be sluggish. Now, why these signs occur? Let's see. Board-like rigidity, which is a classical sign, basically occurs because the peritoneal irritation triggers the reflex spasm of the overlying abdominal muscles. This leads to involuntary guarding. Unlike a voluntary guarding where the patient tenses up deliberately, this persists even on distraction. So this is how you differentiate between a guarding and a rigidity. Rigidity is always involuntary, what we call involuntary guarding. Whereas if you say technically what is guarding, it is a voluntary thing where the patient tenses up the abdominal musculature at the site of the pain. The clinical importance of this board-like rigidity indicates that the patient has got generalized peritonitis. It may be absent in the early stages or in a localized perforation, but it is more prominently seen in thinly built individuals. The loss of liver dullness, because there is a free gas under the diaphragm, this replaces the normal liver dullness on percussion. And the percussion note, if you percuss, would become resonant or tympanic over the liver, unlike in a normal patient which should be dull. This sign correlates with pneumoperitoneum, this loss of liver dullness on X-ray. It is only present in, we'll see later on, it is only present in 50 to 70 perforation of percentage of perforations. Okay, and the referred shoulder pain we have already seen is because of the irritation of the undersurface of the diaphragm, which is supplied by the phrenic nerve C3, C4, C5, and this is also carries this pain via the somatic nerve, which has the same root value at the right shoulder tip. That's why the pain is referred to the right shoulder. This specifies that there is a subdiaphragmatic irritative lesion or a collection. And this can also be a presenting complaint, and patient may be misdiagnosed as having a shoulder pathology. Now, what are the investigations we would like to in this patient? Coming to the laboratory investigations, if you do a full blood count, there would be leukocytosis with WBC more than 12,000, early sign of sepsis, leukopenia and overwhelming sepsis, which signifies as a worse prognosis. Non-specific inflammatory markers like C-reactive proteins and ESR may be elevated. C-reactive proteins may be more than 150 milligrams per liter, which suggests significant peritoneal contamination. Serum amylase may be mildly elevated, perforation because it leads to amylase leak from the gut lumen. LFT and RFT should be done, and because kidney injuries and hepatic dysfunction are common, so it should be done as a baseline. Arterial blood gas analysis we have already seen would show metabolic acidosis, so pH would be less than 7.35. There would be high lactate, more than 3 to 4 milliequivalents per liter, base deficit. Any lactate more than 4 indicates severe sepsis. Blood culture should be taken before giving antibiotics. This would identify the organism and it would guide the clinician about the type of antibiotics to be given. Serum electrolytes, patient may have hypokalemia and hyponatremia, which should be corrected accordingly, and always do a full coagulation profile. We have already seen as prothrombin time and INR may be deranged in late presentation, and patient may require certain blood products like fresh frozen plasma perioperatively. For imaging, X-ray abdomen is the first investigation which should be done. Ideally erect. If the patient is not able to stand, then we can do a left lateral decubitus X-ray. The free gas under the dome of the diaphragm, or which is known as pneumoperitoneum, is only seen in 70 to 80% of perforations. So just relying your diagnosis on free gas under the diaphragm, which may be absent in 25 to 20% of patients, would lead to underdiagnosis or misdiagnosis. So clinical profile along with free gas under the diaphragm should be correlated, and the diagnosis should not be based only on the presence or absence of free gas. Presence of free gas definitely indicates a perforation, but an absence of free gas in the presence of signs of peritonitis does not rule out peritonitis. CT abdomen along with IV contrast is the gold standard investigation. Detects even tiny amounts of free gas which may be missed by X-ray. It would very clearly identifies the site of the perforation, the extent of peritoneal contamination, the associated pathology, like what is the cause, whether it's a tumor, whether it's a inflammatory condition, and it is more than 95% sensitive to diagnose perforation peritonitis. So CT contrast should be done in all patients suspected of hollow viscous perforation. Ultrasound has got a very limited role in that it would only pick up free fluid in the Morrison's pouch or in the pelvis like Douglas pouch. It cannot reliably detect free gas. It is just a useful adjunct in an unstable patient or to rule out any other pathology, but it is not so informative as compared to a CT contrast. This is a classical X-ray of the chest which shows free gas under the diaphragm on the right side. Most visible, the gas would rise above the liver. Look for that dark sliver between the liver and the dome of the diaphragm. You can also see the tented dome of the diaphragm on the right side. That means it is lifted as compared to the left side, the tented dome. Here in this cases, bilateral free gas is seen, especially in large perforations. One classical sign which is seen is Wriggler's sign, also known as double wall sign. Now what is Wriggler's sign? We'll see in the subsequent slide. But again, to reiterate, if the X-ray is negative, perforation is still not excluded because there may be 15 to 25% false negative rate. Order CT scan with contrast immediately. Now this is again X-ray abdomen showing the free gas under the diaphragm. See the crescent shape on the right side just under the dome of diaphragm with slight tenting of the dome. And on the right side you see the Wriggler sign, which is a double wall sign. What is double wall sign or Wriggler sign? That in cases the gut wall is seen as shown in the arrow, and the free gas is present outside, as well as there is an intraluminal gas. So the bowel wall would be seen sandwiched between two gaseous shadows, one extraluminal and one of course the intraluminal. This is a Wriggler sign or a double wall sign, which is classically seen in pneumoperitoneum following a hollow viscous perforation. And this is a CT scan picture with contrast, which classically shows a intraperitoneal free air on the abdominal CT. Now coming to the management protocol, first and foremost is the resuscitation, which is a pre-operative management, which takes a lot of importance because many of these patients, when they report to the emergency department, they may be in shock, they may have certain comorbid conditions, they may not be in an accurate or an exact or an optimal general condition. So adequate resuscitation should be done, and we have a 60-minute window where from diagnosis to resuscitation, patient should reach the operating theatre, ideally during this 60-minute window. The first and foremost is we would do a ABCD as done in most of the patients. First, we would maintain an airway and breathing. So give a high flow oxygen via non-rebreather mask at the rate of 15 liters per minute. Target SpO2 should be more than 95%. Patient should be placed in a semi-recumbent position. Consider early anesthesia review for intubation if the general condition is deteriorating, GCS is deteriorating. Secure an IV access, which is most important, and start IV fluids. Two large bore IV cannula, size 14 to 16G, should be secured. Aggressive crystalloid initially resuscitation. Mind you, in older patients, don't be so aggressive, it can lead to fluid overload. So there's a very thin balance between resuscitation and fluid overload, which should be maintained. Ringer's lactate is preferred for crystalloids over normal saline because it avoids hypochloremic acidosis, and because most of these patients are also in metabolic acidosis. So the lactate in the Ringer's lactate gets converted into bicarbonate in the liver, and this would counter the acidotic environment, leading to optimization of pH. So Ringer's lactate would be preferred. You can give initially 1 to 2 liters and then reassess accordingly. Target mean arterial pressure should be more than 65 millimeter of mercury. Monitoring is very important. We do nasogastric and Foley's catheter monitoring. Insert a Riles tube or a nasogastric tube to decompress the stomach, especially in a massive distension, also to prevent aspiration. And this decompression also promotes peristaltic activity. Insert a Foley's catheter. Urine output should ideally be at 1 ml per kg per hour, which indicates adequate renal perfusion. Minimum urine output target should be 0.5 ml per kg per hour. That means if a person is 70 kg, a minimum urine output should be 35 ml per hour. Ideal should be 70 ml per hour. Always place the patient on NIBP, non-invasive BP monitoring and cardiac monitor. Start broad spectrum antibiotics immediately. Do not wait for any culture reports. Ideally, the antibiotics empirical should cover gram-negative like E. coli or Klebsiella with anaerobes like bacteroids. So we have a very clear option of a third generation cephalosporin, ceftriaxone with metronidazole, or we can also give piperacillin tazobactam combination or a meropenem combination in severe sepsis. Analgesia and adjunct care. IV analgesia in the form of fentanyl may be given, but analgesia generally should not mask peritonism. That is very important. Generally, it is if adequate analgesia is given, the patient is comfortable, and also it does not mask peritonism. That is one of the things which should be taken care of. Always give PPI, IV pantoprazole, especially in peptic ulcer perforation. The infusion is better in this case. Correct electrolyte imbalances, especially potassium and sodium. Patient should be kept nil by mouth, and keep the operation team ready as well as inform the anesthetic team. Take the consent once the patient is adequately resuscitated. Explain the diagnosis to the patient and the operative plan to the patient or to the family. Keep the blood grouping and cross matching at least 2 to 4 units ready in the blood bank. Thromboprophylaxis should be initiated in the form of TED stockings, and low molecular weight heparin should be considered in the perioperative period. Shift to operation theatre as soon as the patient is ready after adequate resuscitation and you feel that now patient is stable enough to withstand the surgery. Now, what is the principles of surgical management? The goal is source control. That means from where the perforation has occurred, that should be controlled first. Peritoneal decontamination, and then finally restoration of GI continuity if it is safe. The source control is the first thing which should be done, which basically means either resect or close the perforation site to stop the ongoing contamination. That should be the first step. This is the most critical step. Everything else is secondary. If you don't do a source control and try to do a peritoneal toileting or decontamination, the leakage would continue and all your efforts would be a waste. So source control is the most critical step. Once you have controlled the source by appropriate measures, which we would see later on, the next step is to irrigate the entire peritoneal cavity with a warm normal saline. Make sure the temperature is lukewarm and not very hot or very cold. Minimum 3 to 5 liters should be used until the effluent runs completely clear. This reduces the risk of residual abscess and ongoing sepsis. Make sure that all the peritoneal fluid, the saline which is used for irrigation or toileting, should be drained out or should be sucked out, and no residual fluid remains which can later become a source of a residual abscess. Damage control surgery should be done in unstable patients who are already into septic shock or coagulopathy. What is damage control surgery? As the name suggests, DCS means do the minimum operation initially to save the life of the patient. For example, close the perforation or pack the abdomen, and later on return for a definitive surgery in 24 to 48 hours when the patient is stable. That may be required, not in all cases, but in few cases whose general condition is not so good. Patient may not be able to take a more lengthy definitive surgery. Patient may be in shock or in coagulopathy. In such a cases, do the minimum required procedure and stabilize the patient for at least 2 days, 48 hours, and then bring the patient back for definitive surgery. This is a damage control surgery which can be done. The anastomosis decisions. Suppose if a part of bowel is to be excised, whether to do a primary anastomosis or not is a very clear-cut instruction that primary anastomosis is safe only in clean fields. And what is clean field? When the bowel is healthy, the leakage is early. That means in the initial phase when there is no bacterial contamination. So if it is done within say 6 to 8 hours post perforation, there is no fecal contamination. In such cases, the chance of holding of primary anastomosis is much more than a creation of a stoma. In contaminated field where there is obvious fecal peritonitis, or the time has elapsed and you feel that there is a bacterial peritonitis, for example beyond 12 hours or 16 hours, in such cases it is always safer to do a diversion. That means create a stoma rather than doing a primary anastomosis. The risk of doing a primary anastomosis in a contaminated field is that very likely the anastomosis would leak in the post-op phase and this would entail another surgery which could not be well taken by already unstable patient. Always drain the abdomen following surgery. Put a pelvic, which is the most dependent part, and a subhepatic drain in cases with significant contamination or anastomosis. This allows early detection of anastomotic leak or any residual collection. So drains are very important here. The surgery to be done, whether open or laparoscopic, depends on the availability of the resources and the expertise. However, laparoscopic approach is feasible for peptic ulcer perforation in stable patients. Open laparotomy would be preferred in hemodynamic instability, massive contamination, colonic perforation, or where the laparoscopic scales are slightly limited. Now, this is a duodenal perforation, which we have seen is already one of the commonest cause of hollow viscous perforation leading to peritonitis. And the classical surgery which is performed in duodenal ulcer perforation is a Graham's patch or Graham's omental patch or a modified Graham's operation. Indication is peptic ulcer perforation, first part of duodenum, most common perforation overall. The procedure is do a midline supraumbilical incision, identify perforation site on the anterior wall of duodenum just under the liver. Biopsy the edge if malignancy is suspected, but in duodenal ulcer it is very rare, but in gastric ulcer definitely biopsy of ulcer should be taken at least from 7 to 8 sites. Place stay sutures across the perforation as shown. 3 stay sutures should be taken, one proximal, one through the suture perforation and one distal to it, 3 sutures. Harvest a plug of vascularized greater omentum as shown in this adjoining diagram. Bring the omentum over the perforation and tie these 3 stay sutures loosely. This would seal the perforation. Once this has been done, which is generally a source control, a thorough peritoneal wash or peritoneal toileting should be done using 3 to 5 liters of warm saline and put a subhepatic drain and a pelvic drain. This surgery is increasingly being performed laparoscopically. Same principles apply, and but it requires, of course, laparoscopic expertise, and it is also suitable for hemodynamically stable patients. Mind you, this surgery is life-saving surgery. It can be done very quickly, and it can, if done properly, gives fantastic results, and patient recovers very well following this surgery. Typhoid perforation, as we have seen, occurs typically in terminal ileum because the Salmonella typhi has a predilection for Peyer's patches in the terminal ileum, which are abundant there. And this perforation generally occurs on the 2nd week end or the start of 3rd week of illness. These hypertrophic Peyer's patches undergo necrosis, which can lead to perforation of terminal ileum. Generally, the location is terminal ileum at the antimesenteric border. It may be a single or multiple perforation, which we had seen in the previous diagram, and this would, once the perforation occurs, all the intestinal contents with bile would go into the peritoneal cavity. What are the diagnostic clues in typhoid perforation? There is always a history of fever for 2 to 3 weeks. The patient's Vidal test may be positive. Then during the 2nd or 3rd week, there may be appearance of pain or deterioration in the fever, and patient experiences signs of peritonism. Patient has relative bradycardia, which is one of the classical signs seen. X-ray would show pneumoperitoneum, and CT would show free air, free fluid in the peritoneal cavity and the thickened terminal ileum. And when these things are seen on CT scan with a history of fever or a Vidal test positive, always assume that this is a typhoid perforation. In such cases, immediate surgery should be done under a course of antibiotics. If it is a single perforation, simple 2-layer closure, absorbable outer, interrupted seromuscular, and peritoneal toileting should be done. If it is a multiple perforations or large perforations of the bowel wall appears to be unhealthy, in such cases, that segment of bowel should be resected and patient should undergo end ileostomy and a mucus fistula. And post-op, continue anti-typhoid antibiotics like cefotaxime or ciprofloxacin for 7 to 10 days. And later on, once the patient recovers completely, at 3 to 6 months, restoration of bowel continuity can be done. A word about Hartmann's procedure, which is very important procedure as a part of damage control surgery, which can be done in large bowel perforation. We have already seen that the causes which lead to large bowel perforation are colorectal carcinoma, especially the obstructive type, sigmoid diverticulitis, volvulus, mesenteric ischemia or ischemic colitis, trauma. It is very important cause of large bowel perforation, especially a penetrating trauma. Now, what exactly is a Hartmann's procedure? It is done in 4 steps if we see. Step 1 is identify the perforation site. So do a midline laparotomy, assess the contamination, whether it's a fecal contamination, purulent, whether it is generalized or localized. Biopsy the omentum if anything is suspected. Take a biopsy of omentum and biopsy also the perforation if you suspect colorectal carcinoma. So take a biopsy, multiple biopsies from the perforated site. Step number 2, after identifying the perforation, resect that part of the gut. So resect the perforated or the diseased segment with adequate margins. Adequate margins means the margin should appear to be healthy bowel. Ligate the mesenteric vessels meticulously to secure hemostasis and remove and send this resected specimen for histopathology. Step number 3 after resection would be creation of colostomy. The proximal bowel should be brought out through the left iliac fossa as an end colostomy. End colostomy. And step number 4 would be the distal gut, which is a rectal stump, should be closed. So distal bowel is stapled or oversewn and left in the pelvis as Hartmann's pouch. This is known as Hartmann's pouch. It is not exteriorized. Mind you, it is not brought out but stays inside within the pelvis. A marker a suture should be placed. So in a subsequent stage when the restoration of bowel continuity is attempted, this can easily be identified. The colostomy reversal or restoration of bowel continuity should be done 3 to 6 months later, not before 3 months in any case, when the patient has recovered completely. Mind you, no primary anastomosis should be done in a contaminated field. This would prevent anastomotic leak and further fecal peritonitis. So this is in a nutshell what is known as Hartmann's procedure. We will see in the diagrammatic representation also. As shown here, we have excised the part of the gut which is diseased. The proximal part of the sigmoid is brought out as an end stoma. The Hartmann's pouch, that is the rectal stump, is stapled or oversewn, which is known as Hartmann's pouch. And later on, after 3 to 6 months, the restoration of bowel continuity can be done. What are the post-op complications following such surgery which should be carefully seen, especially when a patient is brought to the ward? The first and early complications or late complications. Early complications, the most common which you should be careful about is anastomotic leak if there is a primary anastomosis. This would occur on day 3 to 7. So expect anastomotic leak if it has to occur on day 3 to 7 surgery. So signs are increasing fever, tachycardia, the drain output increases and changes also, or immediately do a confirmed CT with contrast, and patient would require a resurgery or maybe a radiological guided drainage if it is a localized collection. Number 2, wound infection or surgical site infection, which is again a possibility because it is a dirty or a contaminated surgery. So the risk of surgical site infection is more than 30 to 40%. Again, you would expect surgical site infection to start occurring from day 3 to 7 post-surgery. It could be a superficial or a deep surgical site infection, and the risk is high, obviously, and in such cases, you have to open the wound, remove all the sutures, debride the wound, and dress the wound properly and allow secondary healing. Residual abscess may occur if the peritoneal toileting is not properly done. Expect residual abscess and its associated signs and symptoms to occur on day 5 to 10 following surgery. Basically, it is a localized pus collection, and the commonest location of this localized pus collection is either in the subphrenic, that means just under the diaphragm, in paracolic gutters, or in the pelvis. These are the three important sites for residual abscesses. This suddenly the patient would have spiking, swinging fever after initial improvement. Do an immediate CT scan, localize the abscess, and try to drain the abscess if it is localized first under CT guidance. If it fails, then open surgery may be required. Prolonged ileus is again a possibility which may persist for days 1 to 5. The gut doesn't recover from peristalsis. Continue nasogastric decompression, IV fluids. Early mobilization is very important, and generally it should resolve by day 5. There are late complications which you should expect beyond the early stages. And first is incisional hernia, which may occur in months to years. Because there is associated wound weakness, patient can go into incisional hernia. The risk also increases along with associated comorbid conditions like poor nutrition, steroid use, obesity. There may be adhesive intestinal obstruction, which is always a possibility. Again, it can occur months or years, and the commonest cause is post-op adhesions. It can lead to small bowel or large gut obstruction, and this would require initial management conservatively, followed by surgery if it does not subside. Stoma complications, if the stoma is created, can occur, like stoma prolapse or retraction, parastomal hernias, excoriation of the surrounding skin, and the stoma counseling should be done to the patients and to the relatives till the stoma is closed. Special situations and differentials, they may be in elderly, the perforation may be atypical. So pain may be minimal in elderly patients. Same also occurs in patients on steroids or in severe diabetes. In elderly, there may be a delayed presentation and higher chances of contamination, which would lead to worse prognosis. These patients are also a higher surgical risk because of associated comorbid conditions. Conservative management in perforation can be tried in a very elderly patient who are poor surgical candidates who you may not be able to withstand a proper surgery. And that goes by the name of Taylor's method, where there is a nasogastric tube, IV antibiotics. If it is a peptic ulcer perforation, IV PPI. Close monitoring and shift to OT if the patient deteriorates. This Taylor's method of conservative management, mind you, is only suitable for patients who are not considered fit for surgery and may not be able to take, they are high risk cases. Don't try to do this conservative management on all cases of perforation. Sometimes this special situation occurs when there is a sealed or a walled off perforation, which may be sealed by omentum or an adjacent organ even before the patient reaches the OT. Pain, suddenly the patient starts to improve, the pain may improve, there may not be any generalized peritonitis, and if you do a CT scan, it would show a localized fluid collection or a walled off collection. There may not be any free gas under the diaphragm. In such cases, if the patient is stable, patient is not showing any signs of deterioration, conservative management may be used in such a cases under close observation. And immediately patient should be shifted to operation theatre if there is any signs or symptoms of any deterioration. And key differentials to exclude in a patient of hollow viscous perforation are: number 1, acute pancreatitis, especially in peptic ulcer disease perforation, acute cholecystitis, where the Murphy sign would be positive, ruptured AAA, abdominal aortic aneurysm, generally the patient has pulsatile mass, hemodynamic instability. Ectopic pregnancy in lower abdominal pain should always be ruled out, because this is one condition which can be life-threatening. So always ask for last menstrual period in the history. Always do a beta HCG in a suspected cases, and there may not be any free gas under the X-ray, but acute pain. In such cases, ectopic pregnancy should be ruled out during ultrasound. Mesenteric ischemia is one very important differential to be excluded. Acute mesenteric ischemia in cases of perforation peritonitis. The classical dictum is pain out of proportion to the abdominal signs. Patient has severe pain, but when you palpate the abdomen, there may not be any signs like generalized guarding or rigidity or rebound tenderness, then always suspect mesenteric ischemia, especially in elderly patients. Now, just a word about high yield examination points. If you are asked most common site of perforation peptic ulcer disease, first part of duodenum, we have already seen that D1 anterior wall. Most common cause would be H. pylori infection plus chronic NSAIDs. First investigation, always erect X-ray abdomen or chest. X-ray findings, pneumoperitoneum, free gas under the right dome. Specifically, always emphasize that 70 to 80% only would show this. If X-ray is negative, but you still feel there is a peritonitis, always do a CT with abdomen, a CT abdomen with contrast, which is a gold standard. And surgery for duodenal perforation is modified Graham's repair or Graham's omental patch repair plus peritoneal toileting. For typhoid perforation, a simple 2-layer closure with peritoneal toileting is enough. The commonest site for perforation in typhoid is terminal ileum on the antemesenteric border and generally occurs on the end of second or third or start of third week. Surgery for colonic perforation, classical is Hartmann's procedure. No primary anastomosis should be done because it's a contaminated field. Peritoneal toileting with 3 to 5 liters of warm saline until effluent runs clear is very important, following the source control. Target urine output in most of the patients always should be ideally 1 ml per kg per hour, minimum is 0.5 ml per kg per hour. The classical antibiotic choice would be ceftriaxone plus metronidazole, which would cover both gram-negative as well as anaerobes like bacteroids, or piperacillin and tazobactam. Just to summarize the things, full thickness breach of hollow organ is leading to peritonitis. Most common is duodenal perforation from peptic ulcer disease. Pathophysiology is chemical, then goes to bacterial, finally generalized peritonitis. Patient goes into septic shock and multi-organ dysfunction syndrome. Hallmark sign on abdomen is board-like rigidity and absent bowel sounds with shoulder tip pain. Ideal investigation, initially erect X-ray to look for pneumoperitoneum and CT if X-ray is negative or suspicion of peritonitis persists. Management, 4-tube resuscitation plus broad spectrum antibiotics. OT patient should reach within 60 minutes. Surgery for Graham's patch for duodenal ulcers, simple closure, 2-stage, 2-layer closure in typhoid. Hartmann's in colonic perforation, always combined with peritoneal toileting. Okay, with that, we come to the end of this important topic. If you have liked this presentation, please subscribe to my channel. Tell your batchmates also to subscribe. I would keep coming back with more and more contents like this. And thank you for watching.